Good afternoon, everyone. My name is Dr. Johnny Hamilton, and I would like to welcome all Chi-Fi Incorporated members to this webinar to learn more about the Chi-Fi Incorporated and National Institute of Diabetes and Digestive and Kidney Disease Partnership. Kidney disease is in women and Kidney Sunday events. All the phones are on mute. Now I would like to turn it over to Julia Jackson.
Hi everyone, my name is Julia Jackson and I'm the Kidney Content Lead in the Office of Communications and Public Liaison at the National Institute of Diabetes and Digestive and Kidney Diseases, also known as NIDDK. I've been at NIDDK for just over 2 years now, working mostly on cross-cutting support, including social media, and working with Dr. Rogers on his weekly radio broadcast, Healthy Moments, which can be heard on stations nationwide. I particularly want to thank the Chi-Fi leadership and all of you for dedicating yourselves to this initiative, and Dr. Johnny Hamilton, who has graciously helped me organize this year's effort. And I'd like to recognize Eileen Newman, who is now retired, but who played a key role in helping grow and strengthen this partnership during the past 6 years. Our speaker today is Dr. Andrew Narva. Dr. Narva is the director of the National Kidney Disease Education Program, NKDEP. Prior to joining NKDEP in 2006, he served as the director of the Kidney Disease Program for the Indian Health Service, IHS. Dr. Narva continues to serve as the chief clinical consultant for nephrology for IHS and to provide care for patients at Zuni Pueblo through a telemedicine clinic. Dr. Narva is a member of the American Board of Internal Medicine Nephrology Subspecialty Board. He has served as a member of the 8th Joint National Committee JNC8 Expert Panel, the National Quality Forum Renal Steering Committee, the Kidney Disease Outcomes Quality Initiative Work Group on Diabetes in Chronic Kidney Disease, and the Medical Review Board of End-Stage Renal Disease Network 15. Again, we want to welcome you all to this webinar. This is the second webinar we have run since the start of our partnership. The last came about because of Eileen and your efforts were noticed by others around NIH, and the National Institute of Arthritis and Musculoskeletal and Skin Diseases, NIAMS, approached us to partner around lupus and lupus nephritis, including co-hosting a webinar. It was such a success that we decided to include a webinar in the presentation for this year's Kidney Sundays event, with information about our partnership, women and kidney disease, and a review of Kidney Sundays materials. We'll have a Q&A at the end of the webinar to address your questions. If you have any questions during the presentation, there's an orange arrow on the control panel to the right of your screen that you can click an Open Questions pane. You can add your questions there. We would also like you to complete a short feedback form that will launch at the end of the webinar so we can make improvements for next year. NIDDK has been partnering with Chi-Fi for Kidney Sundays in March for the past 7 years to reach faith-based communities and raise awareness about kidney disease among African Americans. As you're well aware, African Americans are disproportionately affected by the disease and its main causes, high blood pressure and diabetes. Chi-Fi has also been instrumental in creating additional resources that can be found on NKDEP pages on NIDDK's website. Videos on being a health champion and hosting a Kidney Sundays event can also be found on YouTube. Our similar missions of improving the public's health has made this a wonderful partnership that continues to grow from year to year. The Kidney Sundays program started with 18 churches in the first year and expanded to 146 churches last year. And we expect an even higher number this year. If you plan to participate and still haven't sent in your response, you have time. Please send responses to Dr. Hamilton as soon as possible so we can make sure to get the materials out before February 8th, because who knows what will happen then. The deadline for submitting the materials is Friday, February 16th. For those of you who have already been involved, please think about being a mentor for new chapters and members. Now I'll turn things over to Dr. Narva.
Good afternoon. First, I want to thank all of you and to thank Chi-Fi for the sustained and strong effort that you all made to help reduce the burden of kidney disease, especially among high-risk populations and especially among African Americans. Our program has the ability to develop materials, but relies on partnering with organizations to disseminate and implement those materials. And Chi-Fi has, over many years now, been a great partner and an effective partner, and we appreciate all the time and effort that you donate to help us accomplish our mission. So the program, our program, the National Kidney Disease Education Program, has a mission to reduce the health burden caused by kidney disease and its complications by improving the early detection of chronic kidney disease. And we've done that by standardizing 2 simple tests that are used to identify people with kidney disease, the creatinine and the estimated GFR, which is derived from that, and also the urine albumin measurement, which is also used to define kidney disease and is a reflection of kidney damage. We work to facilitate the identification of patients, not all patients who might have kidney disease, but because clinicians are so busy to try to help them identify the patients who are at greatest risk for progression. We promote evidence-based interventions to slow progression of kidney disease, and there is not that much evidence in kidney disease, but the interventions for which we do have evidence, blood pressure control, use of ACEs and ARBs, blood sugar control in people with diabetes, and treatment of hypercholesterolemia are quite effective and are under-implemented. And then finally, we work to support the coordination of the federal response to CKD. As you know, Medicare pays for dialysis, and that's tens of billions of dollars. NIH supports research, CDC does surveillance, the Agency for Healthcare Quality looks at processes of healthcare delivery to try to improve outcomes. The VA is the single biggest provider of care for people with chronic kidney disease, and DOD also has a significant effort. Other agencies also are involved, and you're probably not surprised to know that in the past they didn't always talk to each other, and they didn't always share their programmatic information, and so we try to bring all the agencies together to talk, and that has actually led to some important cooperative efforts. But overall, if we have to summarize what we're trying to do, it's to bring the chronic care model to CKD. The chronic care model, as I'm sure you're all familiar with, is an empiric model to approach chronic kidney disease, to improve outcomes by having activated patients and a healthcare team that interacts in the most productive way. And that includes optimizing the contribution that nurses can make through care planning, care management, care coordination, and adherence to evidence-based care. So as part of our outreach, we try to reach the community in a number of ways, including the Family Reunion Health Guide. We also have a large number of materials that might be of interest to you for healthcare professionals. Kidney disease is complex and frightening to many patients, but it's also somewhat frightening to many providers as well, for a number of reasons. What we've tried to do is to develop materials that present the needed information in a fairly short and straightforward way. And the booklet that's shown on the right, Making Sense of Chronic Kidney Disease, is really designed for professionals in the primary care setting. And unlike other similar documents, which can be 100 pages long, this is about 16 pages, and really summarizes the basic approach to chronic kidney disease that can be used by primary care professionals. Much of what these materials are meant to do for healthcare professionals is to give primary care professionals, and by that I mean not just physicians or nurse practitioners or PAs, but nurses, pharmacists, dietitians, give them the additional knowledge so they can feel confident addressing kidney disease the way they address all the other problems that people present with in the primary care setting. So the theme of this year's Kidney Day is women and kidney disease, and that's appropriate because women do carry a significant burden of kidney disease. Approximately 30 million people, or about 15% of U.S. adults, are estimated to have chronic kidney disease. What that means is that's a projection from the NHANES data. NHANES, as you know, is a sample of the U.S. population of several thousand people, and they undergo testing and screening, and it's meant to be a representative description of the health of the United States. So if you take the prevalence of either decreased kidney function, elevated creatinine, or protein in the urine in the NHANES population and project it on the U.S. population, you get this estimate. We don't know exactly how many people have kidney disease in the United States because most people are asymptomatic, and people at highest risk come from groups that have decreased access to health care. But we do know quite well the burden of end-stage renal disease, or people on dialysis or with a transplant, because that data is collected by Medicare, and we know from that the rate of kidney failure is about 4 times higher in African Americans when compared to Caucasians. And as I mentioned, most people with kidney disease have no symptoms, and many people don't become symptomatic until they're close to the point where they require dialysis or transplant. CKD is estimated from the NHANES data to be somewhat more common in women, about 16% than in men, and in older people, it's also more prevalent. But also, as you go to older age groups, women predominant over men as well. So, kidney failure does cause a lot of human suffering. It's also a huge burden on our healthcare system. In 2015, about 20% of Medicare dollars went towards patients with chronic kidney disease. Now, obviously that included care of other problems in addition to kidney disease, but gives you an idea of that this is a relatively sicker group of people. And about $34 billion was spent for people with end-stage renal disease, either on dialysis or with a transplant. So it's a huge amount of money, and even more importantly, it's a lot of suffering. What's important to realize about this is that early intervention, which your program, the program that we cooperate on, is part of early intervention, makes a huge difference. If you can identify people early, more aggressively treat their blood pressure, get them on an ACE inhibitor or an ARB, and follow them, even if you can delay the care, delay the need for dialysis by 1 year, which is not that hard, you will save that person a lot of suffering. But in addition, you can save the healthcare system about $50,000. And hopefully, that $50,000 could then be put back into other kinds of preventive health care. So, we have a lot of challenges to trying to improve the care of people with kidney disease. One problem is that kidney disease is underdiagnosed, and that's largely because the routine tests aren't done. It's hard to escape a creatinine if you see a doctor or a healthcare provider. And with all creatinines, generally an estimated GFR, estimation of kidney function, is produced in the lab report. But about half of the people identified with kidney disease have that identification on the basis of a increase in urine albumin, and testing of urine for albumin is very incomplete, and as a result, there are a number of people that we don't identify. The implementation of recommended care is poor, even though the interventions are not complex and not that different from routine diabetes care in terms of blood pressure, use of ACE and ARBs, use of cholesterol-lowering medicine. But the kidney community over time has not been successful in producing materials that make it easier for providers in the primary care setting to implement what's relatively simple care. But a lot of the barrier is cultural, and many clinicians are just extremely uncomfortable with kidney disease. In fact, when I talk to large groups of nurses or nurse practitioners or doctors, I say, you know, most healthcare providers spend their whole careers in recovery from the renal block, the kidney block, whether it was in nursing school or pharmacy school or medical school. And for whatever reason, people find it complicated and intimidating, and they sort of stay away from it. They remain uncertain how to interpret the pretty simple diagnostic tests, which is the albumin-creatinine ratio and the estimated GFR. And just those terms make people really uncomfortable, although they're pretty simple. The clinical recommendations tend to be voluminous, and there are lots of clinical guidelines for kidney disease, but they are usually in the context of a large and cumbersome document, which is written as if the only patients you're seeing are people with kidney disease, and it's not easy to implement their recommendations if you're in the usual primary care setting, where you may have a patient with congestive heart failure, and then a patient with asthma, and then a patient with nosebleeds, and then you see somebody with kidney disease, and then you see someone with a completely unrelated problem. So much of the educational effort has sort of perpetuated the idea that kidney disease should be treated separately from everything else, and it really shouldn't be. Many clinicians, as a result of all this, have a pretty low confidence in their ability to successfully manage chronic kidney disease, and will refer people whose disease could probably be managed by them. And the problem is that if your pattern is to refer a patient to a specialist and the patient doesn't have access to specialist care, nothing may happen. And then finally, another big problem is the collaboration between the primary care team and the nephrologist is not well worked out. And many clinicians, in the primary care setting feel, oh, if I send the patient early, the nephrologist just says, why are you sending them? And if I send them late, then they say, why are you sending them so late? And they kind of feel they can't win. And there's no guidelines that are consistent and that make for a helpful collaboration. But one of the main problems, and one of the main barriers that we're trying to overcome in our collaborative effort with you, is to raise the awareness of chronic kidney disease. And you can see from this slide that if you look at the right-hand column, it says eGFR 30 to 59. It shows that only about 20% of people who've lost more than half their kidney function are aware that they even have kidney disease. And that's clearly a serious problem. You can't do anything about something if you don't know about it. And this is particularly true in high-risk populations, such as African Americans. So what is it that we need to do to improve outcomes for the groups of people who are at high risk? And that's what population management is. It's not, you want to take care of each individual person, but you want to do it in an organized way so that you get better outcomes for a whole group of people at risk. And the interventions are pretty simple. You want to recognize and test at-risk patients, which really just means getting a creatinine and a urine, initially, and then for monitoring. And that's it. If you can follow someone's creatinine and estimated GFR and their albumin creatinine ratio, which is just a spot urine specimen, you can have a lot of information on the presence of disease and also on the prognosis. The complications of kidney disease are multiple, and you need to screen for them in the primary care setting. The patients can become anemic because erythropoietin is produced by the kidney, and that's the hormone that stimulates the bone marrow to produce blood. Patients may become malnourished as a result of a number of factors. The increase in waste products may blunt appetite, but there's other changes that may do that, including depression. And just getting a urine albumin will give a serum albumin will give a good indication of that. And then to monitor for the bone disease, and really it's a calcium and a phosphorus. So the blood tests you need to monitor a patient are CBC and a standard biochemical profile. The third thing is to treat cardiovascular risk, because patients with kidney disease are at very high risk for cardiovascular disease. And so address smoking and address cholesterol. And in fact, in this setting, it can be very helpful to talk to a patient when you say they tell them they have kidney disease, and say, look, you may not, I don't think necessarily you're going to reach dialysis, but people with kidney disease are very high risk of a heart attack or stroke. So the fact that you have these markers for kidney disease, you have urine and albumin in the urine, and you have a decreased GFR, is a reminder that you should especially try to stop your smoking, and especially we should get your blood pressure under control, and especially to take your cholesterol, because it's more likely that someone with chronic kidney disease will die of a heart attack or stroke than to reach dialysis. And that's a very, very important thing to underline. Dietary interventions are very effective for kidney disease, and only a small fragment of people with chronic kidney disease are seen by a dietitian. Even though dietary interventions are very effective, less than 15% of patients starting dialysis have ever seen a dietitian before starting dialysis. Another very important thing to address in the primary care setting is to avoid acute injury to the kidneys. It's thought that acute injuries, what we used to call ATN for the most part, recurrent episodes of that can contribute to the progression of kidney disease. And one of the main causes of that is the use of NSAIDs. If you have kidney disease and you are on an ACE inhibitor or an ARB, or you are on a diuretic, and for some reason you become volume depleted, if you take an NSAID, you can cause acute kidney failure. And it happens actually quite frequently. So part of what we need to do when we are managing patients is to help people understand that, it's very important to take that lisinopril to protect your kidneys because you have diabetic kidney disease. But if you get the flu, or you get pneumonia, or you have severe diarrhea and you get dehydrated, don't take NSAIDs, don't for an acute illness, and you probably also should hold your lisinopril on that day. And these are just preventive things, and this has a lot to do with self-management, because these sorts of decisions are usually made without going to the healthcare setting. But NSAIDs are very dangerous to people with kidney disease, especially if they're on other medicines that affect the blood flow to their kidneys, like diuretics and laces and ARBs. But probably the biggest barrier to improving outcomes is the fact that we don't talk to our patients about kidney disease. So educating patients about kidney disease and its treatment would be the most radical departure for how things are done now. And part of that is because many providers aren't sure what to say. And when people aren't sure what to say, they don't say anything. They're also short on time. And telling someone they have kidney disease is not all that different, at least the emotional impact, from telling someone they have cancer. And if you have 10 or 12 minutes to see a person in an exam room, it's not something you can tell them at 10 and a half minutes with a minute and a half left in the visit. And, oh, by the way, you have chronic kidney disease. It'll be okay. Don't worry about it, but it is of great concern. I'll see you in 6 months. That just doesn't work. And so, and many healthcare providers are unsure about what to say. So I think nurses have a tremendous opportunity here because nurses often talk to the patient more and may spend even more time with them and may understand more about where the patient's coming from. And if you can learn a little bit about kidney disease, you can do quite a bit to help the patients, because we know that a large number of patients start dialysis without knowing anything about kidney disease and not even knowing what their treatment options are. And that's even true for people who are followed by a nephrologist for a year. About a third of people followed by a nephrologist for a year do not have a good understanding of their diagnosis. They don't have a good understanding of their treatment choices in dialysis, and they don't have an understanding that kidney disease can affect cardiovascular outcomes. So all of this is not all that complicated, but it just doesn't get spoken about. And, we look to you and your colleagues to help spread the message in a way that patients can hear it. So you may wonder, I'm a guy at the NIH. I'm telling you all kinds of stuff. I'm giving you advice. How does what I'm telling you correspond to reality? I spent most of my career actually in Indian Health Service, which is a federal agency that takes care of American Indians, mostly in the West, on reservations. And it's a population that has very high rates of diabetes, and it used to be the highest rates of kidney disease and kidney failure. And I'm not going to go to the next slide right now, but I'll show you the results of a program that we implemented, basically using the guidelines of the material that I just mentioned, through the primary care system, through the diabetes care delivery system, without additional people and without additional resources. And it was based on several ideas that kidney disease is best addressed through an approach that creates standards of care for all of the people you're trying to reach. That if you want to make a change, you need to implement it in the community and in the clinical setting, but you have to engage all the health professionals there, nurses, pharmacists, dietitians, physicians, PAs. And there is a model for that. As I mentioned, the CCM means chronic care model. The easiest way to make a change is through the diabetes care delivery system, because there is a diabetes care delivery system virtually in every healthcare setting, and about half of all the people with kidney disease have diabetes. I think the most important thing is not having renal clinics everywhere. It's more bringing a lot of these early interventions, which are simple, into the primary care system. And again, to survey and prevent kidney disease as part of multi-system chronic disease control. In other words, so much of what the kidney community has developed is so kidney-centric that it's kind of irrelevant. And because the fact is, most people who come to clinic with their kidneys tend to bring their hearts and their pancreas and their livers and their extremities. And if you're going to address their kidney disease, it's best to do it in the context of addressing all of their problems. And then probably not to emphasize so much on when to refer patients to the nephrologist, but to just be sure that you've identified what patients need in general and finding people who can deliver it. And in settings where there are a lot of people with kidney disease, the primary care providers become very comfortable. In settings where you don't have a lot of kidney disease, a referral often occurs earlier. These show some results of this effort we made in Indian Health Service among American Indian people with diabetes. And you can see on the left-hand column that the rates of diabetes are the highest among any ethnic or racial group in the United States. And in fact, in the Southwest, where I spent most of my time, approximately half of all adults have diabetes. And when I started as a kidney doctor in the late 80s, the rates of kidney failure, as shown on the right-hand panel, were extremely high, and they had been. This starts at 1996, but it had been going up from about 1970, where it was very low, and it was higher than among any group, including African Americans. And we started a primary care-based approach using very simple interventions integrated into the routine care. And after a few years, after about 10 years, we started to see a real drop in people starting dialysis. And if you follow that green line, you can see that the decrease has been significant. In fact, the rate of American Indian people with diabetes starting dialysis decreased from about 2000 to 2013 by 54%. And of course, not everyone has diabetes, kidney disease from diabetes, but it is the major cause among all groups, including African Americans. So simple interventions put in place in a consistent and coherent way can have a huge impact, and that's what population health is. So, in summary, improving the care of people with kidney disease requires changing clinical settings where high-risk populations are served, and it may be places where many of your members are working and communities that you're serving. The focus should be on care of patients prior to referral and promotion of self-management, and these are self-management is really a concept that was invented by nurses, and it's key to successful outcomes in any chronic disease. And nurses, and I'm saying this not just because I'm speaking to you, but nurses are key to improving care for people with kidney disease. So I'll give it back to Julia at this point, and thank you for listening.
Thank you, Dr. Narva, for the valuable information on kidney disease, the challenges, and then what the nurses can do to address some of these challenges. I'm going to now talk a little bit about the theme of National Kidney Month and Kidney Sunday's materials. As Dr. Narva mentioned, this National Kidney Month, we're working together to raise awareness around kidney disease and to raise awareness around prevention. And we're reaching out to women, especially in African American communities. As women often guide family medical decisions and serve as role models for healthy lifestyle choices, our messages emphasize the steps that women can take for themselves and for their families to adopt healthy lifestyles and keep their kidneys healthy. This includes the importance of testing. You should have already received 2 Kidney Sundays toolkits in preparation for this webinar. If you haven't, please let Dr. Hamilton know and we can send them out to you. And packets will be sent out next month to organizers and churches with additional materials. Chi-AIDify members can schedule National Kidney Month events any Sunday in March. And if March isn't convenient, these materials can actually be used any time during the year. Any Sunday can be a Kidney Sunday. There is a final feedback form both in the packet and online for organizers to fill out at the end to let us know how their events went. Please remind organizers to fill out these forms as we use the feedback to plan future events. The link to the online form is also going to be posted in the chat box where we have been posting other materials that we've talked about, resources from this webinar. The Kidney Sundays Toolkit is the central piece of the event. It contains an introduction, a checklist for getting started, procedures for holding an event, talking points, and additional resources. The checklist is very important for holding an event because it takes organizers through step by step, including who to contact, how to publicize the event, and how to engage the congregation. We will also be sending Dr. Hamilton some social media posts to use in promoting the event to the congregation, and congregation members can share them with their own friends and family. As I mentioned before, we also have a video called How to Host a Kidney Sundays Event, and if you search How to Host a Kidney Sundays Event -YouTube, it'll come up right away. We also will share the link in the chat box. The other materials sent to organizers include a welcome video from Dr. Rogers talking about the importance of awareness of kidney disease, steps you can take to protect your kidneys, and thanking Chi-AIDify for participating in the program. The talking points included in the letter to organizers can be presented as they are, or organizers can put them into their own words. For Kidney Sundays veterans, the talking points are similar to previous years. The additional materials that we're sending to the organizers and churches can be presented to the congregation or laid out on tables. And we know that in previous years, Chi-AIDify members have done blood pressure screenings that were well received. If you have any questions about National Kidney Month, kidney disease in women, Kidney Sundays planning, now's the time to add them to the questions pane. I know I see a couple that have come in. If we don't get to your question today, we can respond via email. And while we wait for some of the questions to come in, I just want to mention that we have a new blog, Diabetes Discoveries in Practice. And this blog is intended to bring healthcare professionals closer to thought leaders who share insights and practical tips to foster a team approach to diabetes in clinical and community-based settings. I encourage you to subscribe to the blog and share your insights and expertise in the comments section in the blog. So a couple of the questions that have come in are if the slides will be made available later, and yes, they will. We are going to be sending them to Dr. Hamilton to send out to the members. And that includes the resources that are part of the presentation will also be sent out in a packet to Dr. Hamilton to send out to all the participants and members. So I noticed that there's a couple of questions, Andy, about the types of foods that people can eat with CKD.
Sure. Let me, are certain fruits avoided? And let me just, sure. So that's an interesting question. For people with advanced kidney disease, potassium can be a problem. The kidneys eliminate potassium from the body, and if you eat a high potassium food like apricots and you're on dialysis, you could end up with a high potassium, and if your potassium goes high enough, your heart will stop beating, and that would definitely ruin your whole day. But it's not as common as you might think, and for people who aren't on dialysis, this becomes a little bit confusing because even people, sometimes very conscientious people, they will look at their lab results and they'll say, oh my goodness, it says my GFR is 55. I have chronic kidney disease, stage 3. Sounds really bad. I wonder what I can do about this. Maybe I can change what I eat. And sometimes they're referred to a dietitian who may be a dialysis dietitian, because there are not that many dietitians who care for people with earlier stages of kidney disease. And most dialysis patients are cautioned to avoid high potassium foods like many fruits and vegetables. So even though the person we're talking about who has, you know, mildly decreased kidney function and a normal potassium may be told to stop eating fruits and vegetables, which they don't need to do. And so what we've done is, based on just a lab test, we've told somebody we put somebody to eat a less healthy diet. And it's kind of the thing that happens because of the kind of fear and lack of understanding that many healthcare providers have about kidney disease. You don't need to limit potassium unless your potassium is elevated. And in fact, for people with hypertension, increasing your potassium intake may be good. And eating lots of fruits and vegetables may also be beneficial because, and this isn't proven yet, but there's some idea that the citrate or the neutralizing substances that are in fruits and vegetables can neutralize some of the acids that are produced in your body and may actually protect your kidneys. And there are a couple of investigators who are looking at making more fruits and vegetables available to people who don't have adequate resources to buy fruits and vegetables and who are high risk for kidney disease, to see if they can sort of reduce the burden of kidney disease in those populations. So yes, it is important because of the potassium, but you have to be careful and make sure there's a problem before you treat it.
Dr. Narva, I think there's a couple more questions that have come in that we might want to address. One is, will the changes in the healthcare system affect kidney research at NIH?
The healthcare system, it's not the healthcare system, it's the appropriation that Congress gives the NIH and the way it is divided. I think the NIH tries to make the best use of the resources that are available and currently spends about $30 billion a year on research. It's the largest funder of biomedical research in the world. Kidney disease, we fund several hundred million dollars worth of research, and since much of kidney disease is associated with diabetes, we spend the amount that's committed to diabetes also indirectly affects kidney disease. I think these are increasingly recognized as important problems. I think the director of our institute, Griffin Rogers, is a very effective advocate and does a lot of things to bring the importance of diabetes and kidney disease and obesity to the public. And you may have seen him, heard him on Tom Joyner, or heard the brief radio spots that he does. So the funding of the healthcare system is more likely to impact availability of care.
So I see a couple of questions about the logistics of Kidney Sundays and the materials being sent out. If you have a place that you would like our materials sent to, please let Dr. Hamilton know, and we will make sure to mail things out to you. Again, we would like to try and get the bulk of addresses before February 8th, but we have our deadline open until February 16th. So please don't hesitate to send addresses over to Dr. Hamilton, and then we will be able to send materials out. I see another research question. Has there been any research with the reasons kidney disease is 4 times higher in the African American population?
Yeah, there's been, reducing healthcare disparities is a very important problem, and it's complicated. So there are there's at least one genetic marker, the APOL1 marker, that is associated with increased susceptibility to kidney disease, but that probably does not affect most people. The biggest opportunities to reduce the difference have to do with access to care, in my opinion. And I'm saying that for two reasons. One, my own experience in Indian Health Service, where by reorganizing how we did stuff, we reduced the incidence by 54%. Indian people, at least in the Southwest, had much higher rates than African Americans, and now they have almost the same rates as Caucasians. The other kind of research that's been done that I think makes this point is there's a researcher who used to be at Johns Hopkins and is now at University of California in San Francisco, named Neil Poe, and he looked at outcomes between African Americans and Caucasians in the general healthcare system and then in the VA. And as you know, in the VA, everyone has that equal access to care, regardless of race, creed, color, national origin, et cetera, et cetera. And the disparities were much, much smaller. So there clearly are differences in people, and there are clearly biological differences in people, and there's clearly genetic differences in people, and those definitely have an effect on the development of kidney disease and its progression. But hopefully in the future we'll be able to address those through new kinds of therapy. But right now, staring us in the face are lots of opportunities to reduce these disparities simply by improving access to care for people who are at risk. And you do that by having broad screening and educational efforts, and then designing inexpensive ways for people who have early disease to receive the relatively simple interventions they need and follow up. And that may mean other ways of doing things than we usually do. But what I showed you from Indian Health Service is a system that makes heavy use of nurses, of community health workers, of everyone who's engaged in the healthcare system, not just the folks directing care at the top, the physicians, NPs, and PAs. But this is a very active area of research and of very great concern. The disparities in kidney disease are as big as in any chronic disease.
If there are no further questions, I'm not seeing any come through. I want to again thank Dr. Norbert for taking time out to be able to speak about kidney disease, and thank Dr. Hamilton for helping organize this year's efforts. And we'd like to thank you for taking time out of your day to participate in today's webinar and for your support and dedication to the Kidney Sundays event. It's been wonderful to be able to speak with you all today. If you have further questions, please don't hesitate to reach out. On the next slide, we have my contact information and contact information for NIDDK. We will again be sending the webinar out and links to all the resources to Dr. Hamilton to share with all of you and anyone who wasn't able to attend today. We want to say good luck with the events, and we look forward to hearing more about your Kidney Sundays. Thank you again, and have a lovely evening.